and my teacher and mentor, Dr. Tanguvelu sir, for choosing me for this topic. So this talk would be on enteric fever. So this is the most common case scenario that we encounter. A 6-year-old girl child is brought to the OPD with history of fever of 5 days duration, vomiting and right-sided abdominal pain and poor appetite. She has been treated at home with oral paracetamol.
Dhakshayani, just hold on for a few seconds. I'll just introduce Dr. Dhakshayani. Probably Selvan doesn't have the CV with him, I think. She's a very upcoming bright star in IAP. Whatever the responsibility is given, she has the habit of doing it in a perfect manner. Nobody else can do that in a perfect manner. Currently, she's a professor of pediatrics from Government Nahapatnam Medical College. She has been the editor of TNSC Bulletin from 2017, 15 now to 2020. Probably tenure may be also extended further also. She's Secretary of IAP CCB Adolescent Health Academy, EB member of Indian Journal of Practical Pediatrics, Associate Editor of Practical Pediatric Digest, Associate Editor of Illustrated Textbook of Undergraduates, Associate Editor of PICU Protocols IJPP Series, a recipient of Dr. VBR Active Pediatrician Award, Young Faculty Award at the National Assembly of Pediatric Emergency Medicine, Hyderabad. Areas of interest are pediatric diabetes and infectious diseases. Sorry for interrupting, Dhakshayani. You can go ahead with your presentation.
Thank you, sir. Thank you so much, sir.
Thank you very much, sir, for taking my responsibility. I could not see the slide. That's why I could not introduce Dr. Dhakshayani. Thank you very much, sir.
Thank you, sir. Thank you so much, sir. I'll proceed, sir.
You can proceed.
Girl child
yeah,
is
please.
Yes, sir. A 6-year-old girl child is brought to the OPD with history of fever of 5 days duration, vomiting, right-sided abdominal pain, and poor appetite. She had been treated at home with oral paracetamol. The child's fever spikes had been on an increasing trend. According to the mother's documentation, on examination, the child appears toxic and has a hepatomegaly. So what is the most probable diagnosis that we make now? And of course, the diagnosis we commonly make is enteric fever. That is because enteric fever is the most common cause of fever without focus. Around 27 million people annually are infected with enteric fever. And more than half of it happens in children. And that too very commonly in children less than 5 years of age. So we'll proceed with the frequently asked questions when it comes to enteric fever. So what does enteric fever mean? Does that equate with typhoid fever? Yes, and not alone. It includes typhoid fever, which is caused by Salmonella typhi, which accounts for 80%, and paratyphoid fever, which is caused by Salmonella paratyphi A or B, which accounts for 20% of all cases. It is an acute generalized infection of the reticuloendothelial system, and as the name enteric fever signifies, it has predilection for the intestinal lymphoid tissue and gallbladder, and that is why the enteric symptoms. So how is the diagnosis of enteric fever commonly made in office practice? The most common cause of fever without focus is obviously enteric fever. So all of us initially make the diagnosis of enteric fever only clinically. Infants and young children, they present with fever, vomiting, diarrhea, whereas older children present with progressive increase in temperature, which is the typical step ladder pattern. This progresses over 5 to 7 days. Children may also present with have a coated tongue, toxic appearance, loss of appetite, abdominal pain, cough, and lethargy. On clinical examination, they might have a hepatomegaly, a soft splenomegaly, a tender abdomen, and relative bradycardia. The typical rash that is described in enteric fever, the rose spots, which are papular or maculopapular, appearing in crops during the second week of illness, present over the chest and abdomen, which has been described in text and literature, is very, very rarely seen in Indian children. So how will you make a definitive diagnosis of enteric fever? Having made a clinical suspicion of enteric fever, we proceed with the lab diagnosis. A total count, which may be normal or low, with a neutrophilia and eosinopenia, may suggest enteric fever with a clinical background. The presence of thrombocytopenia in enteric fever signifies severe disease or the presence of DAVC. The CRP will be elevated, and LFT may show a mild elevation of transaminases. Having said that, the blood culture and sensitivity is the gold standard investigation for the diagnosis of enteric fever. This will have a 90% yield in the first week of illness and up to 40% yield in the 4th week of illness. Bone marrow culture is routinely done in all cases of prolonged fever and in pyrexias of unknown origin. So, prolonged enteric fever children will also undergo a bone marrow culture. This is important because this remains positive even after antibiotic therapy. The stool and urine cultures are not recommended due to poor yield. Next slide, sir. So what is the ideal time to do a blood culture for Salmonella? Blood culture for Salmonella should be done ideally during the first week of suspected illness, preferably before initiating an antibiotic. Salmonella is a very easy organism to culture, and antimicrobial sensitivity tests are important before initiating treatment. Paired cultures are to be sent. The ideal volume of blood would be 5 to 10 ml with a blood to broth ratio of 1:5. Automated blood culture systems like Bactec are available, and this has improved the recovery of the organism and are also cost effective. Next slide. So what are the other investigations available to diagnose enteric fever? The time-tested and beaten to pulp viral test is the most commonly employed test for the diagnosis of enteric fever. This detects the presence of immunoglobulin M and IgG antibodies against the flagellar antigen H and somatic antigen O of S typhi and paratyphi A and B in the second week of illness. So if this comes as positive, this could be typhoid fever or paratyphoid fever. If we are to choose to do viral test, tube method is better than the slide method. Antibody titer of more than 1:160 dilution for both O and H is considered as positive. A fourfold rise in titer in paired samples, which is done 1 week apart, is the conventional method. However, it is less practical. So what are the other investigations available to diagnose enteric fever? The Typhoid test, which is the enzyme immunoassay test, detects IgM and IgG antibodies against the outer membrane protein for Salmonella typhi. So this is specific for typhi, though the specificity is 37%. If this is positive, it would turn out to be typhoid fever rather than paratyphoid fever. Anamnestic reactions are seen with other infections also. That is the issue with this Typhoid test. The newer tests like nested PCR has specific H1B primers directed against S typhi. This helps in rapid diagnosis and could be promising in the future. Next slide, sir. What are the limitations of the serological test? Wider test is the most commonly employed test, but they are not diagnostic, may be supportive, and should not be relied upon alone for patient management decisions. It has very low sensitivity and specificity. False positive viral is seen in malaria, rickettsial infection, or infection with other enterobacteriae. False negative viral is also seen in patients who have been treated with prior antibiotics. Though this test is obsolete, it is being done routinely because this is the most easily available test. Clinicians, but they should differ from diagnosing and treating enteric fever based on this viral test alone. Next up, what are the treatment modalities available for enteric fever? The mainstay of treatment of typhoid is specific antibiotic therapy. Children with persistent vomiting, diarrhea, abdominal distension, toxemia, and complications should alone be treated as inpatients. Otherwise, children with enteric fever may comfortably treated on a domiciliary basis. Having stressed on the importance of specific antibiotic therapy, the importance of meticulous general supportive measures like maintenance of proper hydration, good nutrition, antipyretics, and other symptomatic treatment cannot be overemphasized. Contrary to popular belief, there is no need to restrict any type of diet in cases of typhoid. Next slide, please. So what is the choice of empirical therapy for typhoid fever? Children with severe illness, complications, and children who are being treated as inpatients, the first choice would be injection ceftriaxone, which is given at a dose of 100 mg per kg per day in 2 divided doses up to a maximum of 4 grams per kg. This can be switched over to oral cefixime as soon as possible. The mean time for defervescence of typhoid fever when the child is on treatment with ceftriaxone would be 6 to 8 days. The issue of ceftriaxone resistance is not a major issue in Indian subcontinent. So MIC of less than 1 for ceftriaxone is associated with excellent clinical outcome. The second choice, parenteral drug, would be injection cefotaxime, which is given at a dose of 150 to 200 mg per kg per day, up to a maximum of 12 grams per day. This issue is that it has to be given in 3 divided doses. But when children started on ceftriaxone, developed features of biliary sludging and they are symptomatic and they develop concomitant hepatitis, injection cefotaxime is preferred. Next slide. So aztreonam is another parenteral drug. It can be used at a dose of 50 to 100 mg per kg in 3 divided doses. Can be given only IV or IM. This is the second choice drug, but this can be used only in multi-drug resistant typhoid cases who are allergic to cephalosporins and in complicated typhoid who do not respond to parenteral third generation cephalosporins. Next slide. So what is the drug of choice for outpatient treatment of typhoid fever? The first choice would be tablet cefixime, which is given at a dose of 20 mg per kg per day in 2 divided doses up to a maximum of 1.2 grams. This is available as 20 milligram and 400 milligram tablets, and syrups are available in formulations of 5 ml containing 100 milligram and 200 milligram. The dose should be for 2 weeks, similar in but this is oral, but still similar in efficacy to ceftriaxone and superior to quinolones. The second choice oral drug would be tablet azithromycin, which is given at a dose of 10 to 20 mg per kg per day, once a day up to a maximum of 1 gram per day in uncomplicated typhoid and quinolone resistant strains. This is given orally once a day. So misuse of this drug is very rampant, but this should not be used routinely as it is a reserved drug for extremely drug resistant enteric fever and also in relapses. This causes prolonged QT intervals. So cautious use of this drug azithromycin with drugs which can also prolong the QT interval should be emphasized. Next slide. So when do we expect response to treatment in enteric fever? The usual duration for effervescence in enteric fever is 5 to 6 days in optimally treated cases. Most children, they become afebrile within 7 days of treatment, but therapy should be continued for at least 14 days in uncomplicated cases or for 7 days after defervescence. But this defervescence is a subjective phenomenon. It depends on the caregiver also. So it is imperative on our part to emphasize on the need for treating children with enteric fever for a complete 14 days. Next slide. What is the recommended duration of treatment? So to emphasize again, the duration of treatment is at least for 7 days after defervescence or a total of 14 days, whichever is later. Azithromycin, on the other hand, is used for a total of 7 days. Next slide. So how do you clinically make out defervescence in enteric fever? So clinically, there is subsidence of fever, there is decrease in temperature spikes, return of appetite, and a perceived sense of well-being by the child and by the caretaker. The time taken for defervescence, as stated earlier, would be around 5 to 6 days in optimally and appropriately treated cases. Next slide. What is meant by delayed defervescence? Some children, despite using the appropriate drug in appropriate doses, would continue to have fever even at the end of 1 week. But they are otherwise well. In such cases, there is decreased toxic features and reduced fever spikes and intensity of fever. And there is also quick response to antipyretics. But just that the child has persistent fever beyond 7 days. So this does not warrant change or addition of the antibiotic. Continue treatment with the same antibiotic that was initiated. Just give counseling and reassurance to the patient. So what is meant by clinical failure? This is seen in around 5 to 10% of cases. In spite of using in vitro susceptible drug in appropriate doses, the child continues to have fever with toxic features beyond 1 week. In such cases, switch over to alternate sensitive drugs like azithromycin or quinolones. Do not use antibiotic combinations at any time. Consider other causes of fever like drug fever, thrombophlebitis, co-infections with like malaria, hepatitis A, and complications like infection-associated HLH. If you have tentatively, empirically diagnosed a child as enteric fever and start a treatment, this is the time to redo your diagnosis if you have not done the cultures previously. Review your diagnosis now with careful history, physical examination, and repeat investigations if necessary. Because this child could have not been a case of enteric fever in the first place at all. Next slide. So what is relapse?
Please make it fast. We are running out of time.
After initial resolution is called relapse. This is usually milder. Relapse rate commonly seen in enteric fever, despite appropriate treatment is 5 to 20%. Culture should be obtained and standard treatment should be administered. These cases, they respond well and quickly to the same drug as used for primary therapy, but in appropriate doses and right duration. Quinolones, if not used earlier, and azithromycin are good alternatives. Relapse can be differentiated by reinfection only by molecular typing. Next slide. What is the present recommendation on the use of quinolones? This is obsolete now. This cannot be used in children less than 8 years of age. But this had a short time for defervescence, which was 4 days. If it needs to be used, it should be used at a dose of 15 to 20 mg per kg per day. This is not being used concurrently because of the emerging resistance. This is reserved only for selected cases, especially relapses and therapeutic failures, after doing an nalidixic acid sensitivity report. Because if you have an nalidixic acid sensitivity report as resistant, then you are not supposed to treat the child with ciprofloxacin. Next slide, sir. So what are the commonly misplaced and misused drugs in enteric fever? As stated earlier, quinolone have been used left and right.
Dr. Dhakshayani, we are running out of time. Please make it fast.
Slides, sir. Just
Thank
two
you.
more slides, sir.
Yeah, please. Yeah.
Azithromycin is a reserve drug and should not be misused. Aminoglycosides like amikacin have no role in management as its site of action is extracellular, while salmonella is an intracellular organism. Next slide. The vaccines available for typhoid. Typhoid polysaccharide vaccine is recommended in children more than 2 years of age. Typhoid conjugate vaccines are preferred. The Typhoid BEV vaccine is this vaccine has been approved by DCGA in February 2020. Type-bar TCV, the typhoid conjugate vaccine, have been in use for a long time now. The doses are only 0.5 ml. So this typhoid conjugate vaccine. So next slide, sir. So recommended schedule, typhoid conjugate vaccine would be 0.5 ml given IM between 6 months to 9 months of age. If you are planning to give a measles containing vaccine, both should be separated by at least 4 weeks. This is recommended up to 45 years of age. Boosters are not recommended for typhoid conjugate vaccines as of now. Polysaccharide vaccine is given at a dose of 0.5 ml. It is recommended in children more than 2 years of age, and booster dose is required every 3 years. In children who have recovered from enteric fever, this vaccine should be given 4 weeks after recovery if the child has not received the vaccine in the preceding 3 years. Next slide, sir. So blood culture is the gold standard in the diagnosis of enteric fever. Vidal has many pitfalls. Do not make a diagnosis of enteric fever based on Vidal alone. Complete the recommended treatment for the recommended duration. There is no role for dual drug therapy in enteric fever. Culture positive report prevents unnecessary use of azithromycin, which must be kept as a reserve drug. Vaccination against typhoid decreases the severity of the illness and its complications. Thank you.
So thank you very much, Dr. Dhakshayani, for an elaborate and effective presentation on typhoid. Now I request the next speaker, Dr.